Okay, I'd like to thank everyone for having me here, giving me a chance to talk today about some recent work that I'm doing with how stem cells, which we've been hearing a lot about today, may be a viable treatment option in acute kidney injury. So what is acute kidney injury, or AKI? So it was actually first described during the bombings by, by the bombings of London in World War II by Bywaters and Beale. And really they saw that there was this increase in AKI from crush victims. So literally blunt force trauma caused acute kidney injury. And mortality of AKI in World War II reached about 100%. It was poorly characterized, etc., and there was no treatment. However, in the Korean War, they started using hemodialysis, which actually reduced the mortality rate from 100% to about 50%. And we actually now still get a spike in AKI after things like catastrophic earthquake bonding, etc. But there's other ways to get AKI as well, or acute renal failure. So simply defined, AKI is an abrupt or rapid decline in renal function. So you get a retention of nitrogenous waste, things like creatinine, blood urea, nitrogen. And this renal function decline over the time course of hours to days. So the main causes of AKI are dramatic reductions in renal blood flow and toxicity. There's several nephrotoxic drugs that can cause harm to the kidney. AKI is a leading cause in nephrology consultation in the U.S. It occurs in about 5 to 7% of hospitalized patients. So we actually get a lot of incidents of AKI in the ICU. And treating AKI is expensive. So it results in about 17 million hospitalizations, hospital admissions each year, costing the healthcare system approximately $10 billion annually. So you get this rapid decline of AKI from, let's say, reduced blood flow. But there's other pathologies, let's say diabetes, which we all know is a huge problem, that can predispose one to AKI. So diabetes, you have an increased risk of acute kidney injury, which gives you about a 6 times more likely chance of death. Diabetes and AKI also can lead to an increased risk in CKD, or chronic kidney disease. And then this can then progress to end-stage renal disease, where people are on dialysis, and if you know anybody on dialysis, it's not a way to live at all. And eventually, if you're lucky enough, renal transplant. So 100,000 Americans are currently in need of kidney transplants, and most sit on the waiting list for an average of about 3.5 years. So in 2014, over 17,000 kidney transplants took place in the U.S., which sounds like quite a bit. However, over 3,000 new patients are added to the kidney waiting list each month. So it's a real problem. So this is the sort of the natural history or life cycle of AKI. So we have renal function on the ordinate and time on the abscissa. Now, if you get hit particularly hard with your insult, you may lead to end-stage renal disease and death. Or a large proportion of patients actually recover. So you get this decline in renal function, but you do get recovery, and most of the time people can live normal lives. However, you see these two that you have this decreasing in renal function. So AKI to chronic kidney disease, and then something called acute on chronic kidney disease. And this is really what we're interested in the lab: how to prevent AKI and how to prevent the progression of AKI to CKD. I'm not going to get into the nitty-gritty too much on the pathogenesis of AKI. I just want to point out that during an injury, you get injury to the tubules, or sort of like the workhorse of the kidney, salt and water balance, etc., which lead to decreases in renal function. However, tubules can regenerate, and often do. Another hallmark of AKI is microvascular injury, so damage to the small vessels of the kidney, and inflammation as well. And inflammation plays a role in both tubular injury and microvascular injury. And unfortunately, these small renal vessels cannot regenerate yet. So following injury, you get this renal blood flow is altered following ischemic AKI. You can see this is a normal kidney on the left, and let's just concentrate on this yellow here. That's the outer medulla. So in a healthy individual, you get about 56% of cardiac output to the kidney. However, following AKI, you get a rapid reduction in the outer medulla. And this is because of that damage to the microvasculature. So we raise a question. So if we protect these capillaries, these small vessels, can we reverse AKI and prevent CKD? So there's definitely a need for new therapy of AKI and kidney disease. So in 1954, AKI presented with 50% mortality rate. Fast forward to the current time, still 50% mortality rate. And this is unacceptable. And why is that? Because there's no new effective treatments to alter outcomes. So it was our goal then to see if we could come up with new therapy for treating AKI. Now, stem cells in AKI is not new. There's actually a few clinical trials that have been using bone marrow-derived mesenchymal stem cells in AKI. However, these were largely unsuccessful. And this is because we think maybe it was poorly planned, maybe they're looking at the wrong things, etc. So we took it back out of the clinic and back into the laboratory. And so I study AKI in a rodent model. And so here's what we did to investigate stem cells in AKI. So I did a bilateral renal ischemia on my normal lab rat. At the time of reperfusion, so this means I occluded blood for about 40 minutes. As I let blood flow back into the kidneys, I injected approximately 2 million human adipose stromal cells into the suprarenal aorta. We then evaluated renal blood flow, see if we could restore renal blood flow, decrease the severity of AKI. And we think that that's possible from these stem cells because we think they may be conveying capillary preservation and reducing inflammation. And we're hoping then that the capillary preservation effect, if we do see that, would also decrease the chances of developing CKD. So what do these cells do? So this is a survival plot. You have percent survival on the ordinate and then days post-injury and injection on the abscissa. And as you can see, compared to animals just receiving vehicle, the human adipose stem cells conveyed significantly higher survival rate, about 90%, compared to animals that just got vehicle, which was about 70% survival. So these cells do appear to be beneficial. Now looking at renal injury, we have serum creatinine on the ordinate, day on the abscissa. So as you see at day 1, there's no significant difference between vehicle-treated and human ASC-treated. However, at day 2, you see this improvement of renal function. And that change can be seen here, whereas actually renal injury got worse in vehicle-treated animals. However, we saw that renal function actually improved with animals receiving the ASCs. Another way we characterize injury is looking at the morphology. And so you have a normal, healthy kidney here, and you can see these are all happy tubules, no injury whatsoever. Now, if you look at an injured kidney, you don't have to be a pathologist to know that this is quite damaged, right? You're getting significant damage to the tubules and vessels here. However, in animals treated with ASCs, it looks remarkably just like sham. So it's improving renal function as well as conveying significant protection in terms of morphology. So another thing we looked at is, of course, capillary density, which I talked a little bit about today. And we've shown that there's always permanent damage to these microvessels. So we looked at the microvessels in both the cortex, which is the outer rim of the kidney, as well as the inside of the medulla. And so here's sham. So this is a healthy animal that's not been injured. And this is a stain just for capillaries. You can see there's significant staining of capillaries there in a healthy kidney. However, looking at the vehicle-treated animals, you see a significant reduction in that immunofluorescence. However, in animals treated with the human stem cells, you see then significant capillary staining once again. And we quantified that here. So in the cortex, we had a significant reduction, about 15% in capillary staining in animals treated with vehicle. However, in animals given ASCs, we get this significant reduction then, or a significant improvement in capillary density both in the cortex as well as in the medulla. And lastly, I just wanted to say that I had mentioned, so our goal is looking at capillary preservation. We're also interested in inflammation because we know these cells have some anti-inflammatory effects. And in fact, we did see that. So this is just a cytokine, some inflammatory marker in the kidney. And we looked at that. So you have sham here. You see a significant increase in these infiltrating inflammatory cells in vehicle-treated animals. However, a significant attenuation back down to sham levels in animals given these stem cells. So hopefully today I convinced you that these stem cells are potentially a viable option in the treatment of kidney injury, and we're hoping to move from the lab back into the clinic soon. So these human stem cells improve renal function, decreased inflammation, and preserve capillaries. And we're very excited about this. And we think that this protection of renal function might be able to be used in the climate of diabetes, hypertension, organ transplantation, et cetera. And we really feel like the possibilities are endless. So I'd like to acknowledge my main mentor, Dave Basil, who studies kidney injury. A lot of good work from Purvi Malhotra. And then our collaborators at the ICVBM. And I'd also like to thank the Cryptic Masons Medical Research Foundation, which allows a lot of this work to be possible. Thank you, and I'll take any questions.